And what is the treatment success rate with the older regime vis-a-vis the newer BPAL regime, which is now in use?
So with the older regime, the treatment success rate is around 70%.
Good.
And BPAL, it's better, sir. So it's around 78-80%.
Yeah, more than 85%. Yeah.
Patient was diagnosed as a case of MDR disseminated tuberculosis with involvement of pulmonary, lymph node, and abdomen.
So again, the grouping of anti-tubercular drug. Anyone? Akash? Yes.
For MDR TB, we divide them into Group A, Group B, and Group C, sir. Group A has leoflox, linezolid, and bedaquiline, sir. Then Group B has clofazimine, cycloserine, and then the other drugs, the high-dose isoniazid, delamanid, pyrazinamide, amikacin, these are included in the Group C drugs, sir.
Okay. So this BPAL regime, what we have been talking of, the also WHO as well as the newer tuberculosis elimination program, they have also advocated this. So what is the dosing and what are the drugs to be used in BPAL regime? I think I can, someone from chest, resident from CTC. Have you started this BPAL regime? Yeah. So what all drugs to be used and what is the dose?
The BPAL regime, which we have, bedaquiline is 400 mg OD for 2 weeks, then followed by 200 mg OD thrice a week. And then we have then linezolid, sir. Linezolid, there were 3 trials done in which they saw that 600 mg OD dosing was the most efficacious, sir. Then predominate was there, sir. And
What's the dose?
200 was there, sir. 200.
Okay. What else?
And they have now upgraded to BPAL M also, sir, which includes the moxifloxacin.
Moxifloxacin. So yeah, next to you. Just keep standing from CTC. Now, just tell me, what are the pre-treatment evaluation would you like to do if the patient has to be started on this BPAL regime?
BPAL regimen, sir.
So you have 2 things, clinical evaluation and lab. Just tell me the salient points, what all you are supposed to ask.
Sir. Initially, ECG is done, sir.
No, clinical evaluation first. I told you 2 points. Na? What all in clinical evaluation you will be looking for?
First of all, the inclusion criteria for the BPAL regimen has to be met, sir. There should not be an extensive disease or a cavitary disease that has to be there.
And then history of any drug use?
They would not be exposed to any of the drugs for at least 1 month. More than 1 month, if they are exposed, then we are not supposed to start them.
And in clinical examination, what is the salient points we are supposed to look for? So one is BMI, weight, height. What else?
Yes, sir.
It is related with the adversities of the drug.
Sir, in bedaquiline-based regimen, sir, cycloserine is being given. So there can be psychiatric.
My question is, in clinical examination, the patient has come to you, you have started on BPAL regime. So what all particular things would you like to see in the clinical examination of the patient?
Sir, if there is anemia, sir, when we
are anemia could be one of something more common, peripheral neuropathy, because this regime can show a very meticulous examination about the peripheral neuropathy. Sir, so that is very important. What about the lab? Next to you, yes.
Sir, in lab, first we need to have a CBC to rule out, because these drugs can cause pancytopenia.
Okay,
anemia,
good. What next?
Leukopenia. Then we should have a ECG baseline to rule out, because if the QTC is more than 470 in females and 450 in males, and if they're symptomatic, then we have to think before starting bedaquiline, sir. If they're not symptomatic, then we can start.
X-ray and ECG. That is, they are also equally important, because all these conduction abnormalities, this is actually absolute contraindication in this subset of the patients.
Also,
okay.
LFT, sir, because we cannot start if the bilirubin is more than 2.
Yeah. So any liver dysfunction, that is also the contraindications to this. Okay. Is there any limit of HB after which you need to stop this regime?
8.5. If it is less than 8.5 or.
And which is the culprit drug in this regime?
Linezolid is the main culprit which causes pancytopenia.
Yeah, myelosuppressions as well.
Yes.
Good. So proceed. Next.
Presently, the treatment regime which we are following are the short course oral regime with bedaquiline, and there's another regime which is a longer MDR TB regimen, which is about 18 to 20 months of duration.
So exclusion criteria for this we have already discussed. Any conduction abnormalities or extensive TB disease where you have bilateral cavitary disease or extensive parenchymal damage, there also it is not indicated. Then severe extrapulmonary like any CNS TB, there also it is not indicated. Then in pregnant and lactating women, this is contraindicated, and in children below 5 years. So can I have any pediatric resident? What is the guideline as per the National Tuberculosis Elimination Program if we have to use this BPAL regime? So first you have to tell about the age criteria.
Sir, BPAL regimen is not recommended below 5 years of age.
Yeah, good.
And weight weight should be more than 15 kg. So BPAL regimen is mainly recommended for weight more than 15 and age more than 5 years of age.
Okay, what about in this subset of the patient between 5 and 14 years of age? If you have a children between this 5 and 14 years?
Sir, then according to sir, dose is dependent on the weight, sir, between 5 to
It
15.
is not weight. It is a basically multidisciplinary call based on the pulmonologist and of course your pediatrician. And because there are very not much of trial is into the pediatric age group population. Okay, so less than 5 years, of course, absolute contraindication is there. Between 5 to 14 with consultation with pulmonologist and with the multidisciplinary approach, case to case specific base, you can start these patients on BPAL, but evidence are very, very low, trials are very low in this subset of the patients. Okay. Yeah, so this is the weight band. Most of you have kept this question for the undergraduates. You all are aware. Next. Okay, so again, someone from pulmonology, CTC, resident from pulmonology. Apart from the routine adversities of this ATT, tell me out of this first line ATT, which has got maximum CNS penetration? Can you just tell me percentage wise, how much is for, which has got the maximum penetration within this first line?
Isoniazid has got the maximum CNS.
No, you are wrong. Anyone else?
Pyrazinamide has got.
Yeah, so it is paraginamide, okay? What is the percentage of CNS penetration?
95 to 100%.
Yeah, very good, 95 to 100%. But in CNS tuberculosis, mostly in our setup, we generally don't use this. We use which regime?
Toys regimen.
Streptomycin is the preferred by the neurologist, okay? What is the penetration for streptomycin?
20%.
So why then, in spite of this less penetration, why in CNS tuberculosis, neurologist or even most of us, we are using this SLE regime? What is the answer for this? So this is the homework for you, okay? Okay. So this is the CNS penetration. So here you see paraginamide is with 95 to 100% of the penetration. It is not isoniazid. Next.
As
Oh,
per
yeah.
As per the latest NTP guidelines, the BPAM regime has been introduced with the consensus to adopt a shorter regimen. This is about 9 to 11 months and replacing ethonomide with linezolid. 26 to 39 weeks of BPAM regimen is usually given for more than 14 years of age, while shorter oral regime for less than 14 years has been based on certain eligibility criteria.
So can I have anyone PSM resident? Why, as from the National Tuberculosis Elimination Program, why this regimen has given more importance weightage over the previous regime? And this may be related with, we are hub for some of, what is STA? The Department of PSM is a hub for STA. What is STA?
Sir, health technology assessment.
Okay, so I've given you a hint. So can you tell me?
Sir, it has been observed that it is more cost effective
Good.
when we are dealing with the early
Yeah,
treatment
so it's more cost effective compared to the previous regime. So,
and better result.
yeah, right.
Patient was at Command Hospital, Bangalore. He was started on broad spectrum antibiotics and supportive measures with ATT was also initiated and ART was continued till now. And he was transferred to AICTS for further management of MDR tuberculosis. At AICTS, he was continued on the bedaquiline based regimen. But however, he had worsening breathlessness as his MMRC had worsened from 2 to 3. X-ray had revealed features of right-sided pleural effusion, with ultrasound was suggestive of loculated pleural effusion bilateral, with right more than left. Following which he underwent a therapeutic paracentesis and a pigtail insertion.
So what are the indication of this therapeutic thoracocentesis? Yeah. Yes, vertebral. Major vertebral.
So,
Commonly we have been doing in most of this. So just tell me the indications.
most common indications are any loculated pleural effusion, sir,
Okay.
or any empyema, or if any pH is lesser than 7.2, and any large massive effusions can also be drained with thoracocentesis, sir.
Okay. And positive Gram stain or culture if the pleural fluid is there, and pH also you have described. Okay.
Patient initially was only desaturating on exertion. However, since his respiratory symptoms had worsened, he became hypoxemic at rest. His ABG had revealed increased alveolar gradient with type 1 respiratory failure, and CT scan was suggestive of diffuse ground glass opacities with nodular opacities. On this basis, a clinical diagnosis of PCP was considered. So treatment regimen for PCP, generally we follow the first line treatment is trimethoprim and sulfamethoxazole, with dose being in trimethoprim is 5 milligram per kg and sulfamethoxazole is about 25 milligram per kg. For adult dose, it comes out to be 2 tablets of double strength 8 hourly. And the alternative agents which are available with us are pentamidine, clindamycin plus primaquine and etavoconazole.
So Rajesh, any bedside test you are supposed to do for this PCP?
Sir, we do a 6-minute walk test, sir.
Okay.
And we
and
look for
just quickly tell the adverse effect for this sulfamethoxazole.
So it can cause
What strength of the tablet we are using? It's a very wonderful drug. I've been using most of the OIS prophylaxis.
so we use a double strength tablet, sir. Single strength, double strength, both are available for prophylaxis.
What is the adverse effect?
So adverse effect include hepatitis, sir. It causes transaminitis. It can cause QTC prolongation. It can
Okay.
cause.
And tell me what are the indications for steroid use in case of PCP? This patient was diagnosed with PCP also. So when we should be using steroid?
So it is based on the severity of PCP, sir. Moderate and severe PCP pneumonia, it is indicated to use steroid. So that is PO2 of less than 70 and A minus A gradient of more than 35. We can use.
Good. Proceed.
Patient was managed with Septran and steroids. However, he developed thrombocytopenia, following which his regimen was changed to primaquine and clindamycin. Over the next 7 days, he developed altered sensorium on day 7 after treatment, and he had an episode of GTCS. His neuroimaging in the form of NCT head and CCT brain were normal. CSF analysis was done, and his protein was 47 milligram per deciliter, and there was no hypoglycemia. And cytology was about 1 to 2 lymphocytes. His CSF for cryptococcal antigen and CSF for multiplex PCR was negative. So he was continued a broad spectrum antibiotics, following which sensorium had improved.
So what are the cause of seizure in HIV? This Garvita, our patient, he had an episode of seizure. So just enumerate few of the conditions quickly.
Due to TB meningitis.
Okay.
It could be due to toxoplasmosis.